introduce Professor Ray Mahoney. He's a descendant of the Bidjara people of Central West Queensland and is a visiting scientist at the Australian mHealth Research Centre, investigating the delivery of culturally safe mental health care. He's a Professor of Aboriginal and Torres Strait Islander Health and a discipline lead for population health in the College of Medicine and Public Health at Flinders University. He's passionate about leading research into culturally safe care and addressing racism in healthcare. Ray will talk to us today about best practices in design, development and implementation of culturally safe e-health interventions. Welcome, Ray.
Thanks. Thanks for the introduction. I hope everyone can hear me all right. That's fine, thanks. What I might do, yes, is first of all is share my screen. So can people see that okay?
Yeah, we can see it, thank you. Oh, actually it's in, we can see your notes as well, so you may have to change the view to just slideshow.
Yeah, there.
Yeah, and then I think if you click on that.
How's that?
Yeah, there you go, perfect, thank you.
That's much better, yes. Not that there's a lot of notes involved. All right, so thanks. Yeah, so I really appreciate the invitation today to talk. And I want to talk about a couple of things that we've been working on here, and that's co-designing e-health programs and interventions with Aboriginal and Torres Strait Islander people, and talk about best practice culturally safe e-health. And I'll sort of step you through like a case study of some work we've done, and then talk about the best practice program. First of all, it's my honour and privilege to acknowledge and pay my respects to the traditional owners of the lands from where we're all joining today from across the country, and in particular recognise that I'm coming from the lands of the Turrbal and Yagara peoples, and recognising them across the north and south of the Brisbane River. And finally, and most important, I'd like to acknowledge that our people are Australia's first scientists, our first educators, and our first healers of illness. So thank you. Right, I think it's important I spend a minute or two talking about my background and how I got to where I am today. And my people are Bidjara people from Central West Queensland. It's a small community area, about 800 k's directly west from Brisbane. My mum grew up out there on those lands, and I still have many cousins and relatives throughout Western Queensland. And my role over the last few years, I've had the privilege to spend time out on country. So it's been great. My journey commenced growing up in Brisbane, and over the years I've had different roles in Brisbane and in New South Wales and in Victoria, working in the space of public health, health information, and Aboriginal and Torres Strait Islander health policy areas. And I have a background of research around cardiovascular research and combating racism in healthcare. So that's kind of like a bit of a background, but very much driven by my very strong cultural connections with our people, and my role to improve the health and well-being of our people. Where I am now, I'm currently very privileged to have a role of Professor of Aboriginal and Torres Strait Islander Health with Flinders University and the College of Medicine and Public Health. And I'm also discipline lead for population health. So that's really an important role for me to have. It provides a great opportunity to embed cultural knowledge and cultural content across our Master of Public Health program and our undergrad Bachelor of Public Health. And these are great programs that provide opportunities for people from across the country to enrol and be part of the program. We have a fully online version and people can do it face-to-face. So it's a really important program. And we have people from Queensland, many states involved. Also, am leading capacity building within other academics within the discipline area and developing pathways for fellow Indigenous people to come through into HDR programs to MPhils or PhDs and supporting undergrad and postgrad work. But I'm also developing a research program that's sort of built on a foundation that I've been lucky enough to develop in partnership with CSIRO and the Australian eHealth Research Centre. The Australian eHealth Research Centre is Australia's largest and longest serving digital health research facility. It's been going for almost 20 years and it's a joint venture with Queensland Health. I won't go into all the detail around the eHealth Research Centre, but this work we've been doing focusing on Aboriginal and Torres Strait health has been strongly supported and led by our CEO, David Hansen, who some of you might know. For many years, I filled a role as a research scientist within the centre, and now that I've transitioned to Flinders University, I still have a role there as a visiting scientist. And I'll talk about some work research we've been leading over the last few years in co-design, and I know that's been a strong theme of today's talks, and I'll step you through our approach to co-design. And it's built on a foundation of building strong relationships and productive partnerships with community, and then leading into conducting feasibility trials. But also I want to talk about what we're doing to advocate for and establish a e-health research agenda. Another area of work that I'm leading within the centre here is in evaluation, health program evaluation and co-designing that sort of work with community and with hospitals and health services. But I won't talk about that today. I really want to focus on our work in the e-health and mHealth space. As I said, I'll talk about, digital health platform here, the co-design and the best practice framework. So if I get started first, I'm going to talk a lot about in the first few slides about a particular mHealth platform that was developed in here at CSIRO, and it's currently being used for a number of conditions quite extensively at the moment to manage gestational diabetes. But I'm going to talk about an application around hypertension shortly. But just to explain it in a little bit more detail, and it's clinically validated through other trials around cardiovascular disease earlier on. And it involves a smartphone app that patients enter readings and data and measurements. And the data sits in a, as it says in the slide there, centralized database in the cloud that the health team can access in real time. So the clinical team can monitor what's happening with your patient, and the patient can see on their phone, on their app, how they're going, and provides historical data, and it has proven to be quite successful and really beneficial tool for managing conditions, chronic conditions. So that's the platform that I'm going to talk about, but I'll just talk about our application of that platform. And it's really like a foundation for remote monitoring in a virtual care space for individuals and for clinical teams. So when I joined CSIRO and becoming familiar with the platform, one of our approaches was to look at how could this platform be utilised within the Aboriginal and Torres Strait Islander community control sector, which is an important sector for providing healthcare to Aboriginal and Torres Strait Islander people across the country. There's about 150 services, many very large GP clinics with satellite services associated with them. But the important thing is they're community controlled They're run by a board of local community members. When I say local community members, I mean leaders in the community and elders making decisions about the day-to-day well, the CEO makes the day-to-day decisions, but the board provides strategic management of the program. So it's truly community controlled. And in our space that I work in, it's often and one of the most important first ports of call, if you like, when engaging with the community in developing interventions. So we partnered with the Queensland Aboriginal and Islander Health Council, which is the peak body representing the 25 or so ACCHOs in Queensland. And Quaker are affiliated with NACCHO, which is the national body that overarches all the services. So we met with our partners at Quake and talked to them about the capability of the platform and discussed with them what could be the best approach to engaging with their member services to consider how this platform could be developed and adopted for potential use within their models of care. So we negotiated and worked with them, and in their capacity as the peak body and they within their research and evidence team, they had sort of identified through their work that there are a number of Aboriginal and Torres Strait health services, ACCHOs across the state that had particular interest in, research, cardiovascular health, innovation, and maybe e-health, mHealth. So with their guidance, we reached out to a small number of services and invited them to participate in some discussions around how we could utilise e-health to support chronic disease management. And over a period of time, we scheduled a number of meetings with the services that are on the slide here across the state, and met with them to talk about how e-health could be beneficial. Now, some really important things is that we weren't prescriptive around who attended these meetings. We allowed the ACCHOs to determine that. And we stressed that we weren't there to conduct focus groups. We hadn't started a research project yet. This was the important first step around co-design before presenting with a completed research application and a consent form. It was about sort of doing these first phases with them. And we were very mindful to fit in with local research, existing research protocols, and we'll talk about them a bit more in a minute, but also to fit in with their schedules and go onto their lands, if you like, to talk to them. So, what emerged in those discussions? Some key themes, and most of you online today will be, I'm assuming, will be familiar with some of these themes and challenges for this particular, or some particular groups of people out there. And what kept coming back to us was things like access to reliable, affordable internet and mobile coverage, which sadly is still a case in many parts of Australia. And they identified the value of how this tool could be used to support education and information sharing, especially around health prevention. Things like interoperability, which I'm sure we'll all hear a lot about, kept coming up as critical to improving the way health information can better serve our people. But things like patient ownership of data and becoming, I think, a greater role in owning their patient journey and their health data, because often it's not often enough. We don't see it as a two-way street. Often it's people taking information and readings from our patients. So there are a number of really powerful themes and sub-themes that came through. But of course, how can e-health and mHealth be better embedded into the existing models of care, which are very successful in supporting and providing care to our people? So some of the outcomes, key outcomes, were that I was able to, in partnership with some support, start a journey for Mr. Andrew Goodman, capacity building journey as a PhD candidate. Andrew's getting close to completing his PhD now, and he's doing that with the UQ and the Faculty of Medicine in the School of Public Health. We were fortunate to receive a Heart Foundation Research Award to support part of that journey, which was of course fantastic. And throughout the journey, he's been supported by a top-up scholarship from CSIRO, who have been continue to be very supportive of Andrew's journey. But importantly, we made a commitment to return to the communities that gave up their time with us, to return to them and share the findings of the work we did, the scoping. And we conducted those visits. And another thing is we made sure that we worked closely with Quake around publishing the report. I'm not saying we dumped the data on them and said, write the report. We worked in partnership with them to write the report, but it was published through their support. But also I was provided with an opportunity to present in November 2020 at their annual AGM sort of members meeting and talk to them about the findings as well and the value of e-health. And as a result of that, we had a couple of the services put their hand up and say, look, we're really happy with the time we spent with you on the project. We'd be interested in being part of a feasibility trial. And this is Andrew's PhD project, where we're kind of asking it's a simplified version of the question around, can mHealth support hypertension management with Aboriginal, the clients of that Aboriginal health service. And we're kind of knee deep in that, but some really quite powerful learnings are coming from that work around partnering with Aboriginal and Torres Strait Islander health services in North Queensland and sort of building those relationships and having that sort of strong engagement with the services and being very responsive to their, to their timetables and their needs. Now, I don't need to highlight the impact of COVID on this piece of work over the last couple of years. Our community, and in particular our Aboriginal and Torres Strait Islander health services, have been at the forefront of protecting our people. So there were periods of time where, certainly research was low on their priority, and so we've been able to luckily navigate that journey over the last couple of years. So that's a case study, really important case study that's been quite very, very informative for us. But from the outset, we took the approach that, we aren't the experts. Well, sometimes we think we are, but within our small team, sure we had expertise around e-health in the centre, but as far as for Aboriginal and Torres Strait Islander health and people, we acknowledged that we needed some support, and so we established a collaboration a few years ago. We call it a collaboration, and we have partners involved in that collaboration with us, guiding us along the way, from Queensland Health, QUT, Quake, University of Queensland, obviously CSIRO, and now Flinders, now that I'm part of Flinders. So that's been very instrumental in providing us with some, guidance and leadership around approaches. And one of those very important outcomes or inputs from this piece of, from the collaboration has been developing a best practice framework, because, we approached it, we obviously did our diligence around looking at what other work has been done, but we thought there was potentially a gap there around providing some guidance, and if you like, a framework for other people who go on this journey, working with Aboriginal and Torres Strait Islander people. So as a part of Georgina Chalberg's PhD, we've recently had published a best practice guideline for developing, e-health. And while it's that guideline, and I'll talk about that in a second, has been published, next phase of work is developing the framework. So what do we know about the importance of the framework? We know that Aboriginal and Torres Strait Islander people are using e-health not just in Australia, but internationally, and it's becoming an important part of healthcare. And we know there's a number of really successful mobile device and platforms that have been already in being used. And we know that there's a whole range of direct and indirect benefits to our people being able to sort of utilise e-health and mHealth in settings and in the way that best suits our people. But, we need to be mindful that there's a history of generally, not just in Indigenous health, but just generally around developing e-health and mHealth, in particular mHealth. And they often follow a cycle around, app development and delivery for a limited period of time, and then because of funding, or it might be attached to someone's PhD or something, then the maintenance and updates of that falls by the wayside, or we don't know a lot about the usability of it. And in particular with Indigenous or Aboriginal and Torres Strait Islander focused mHealth, we see sometimes it might be an approach where co-design is seen as a tool or just a process around indigenising an app, like adding motifs or different colours to it to appeal to our people. Now that might work, it may not work, but we certainly, with our approach and what we're hoping to develop with the guidelines, is an evidence base and a process to take it beyond potentially superficial changes. And build a stronger evidence base. So why? I mean, I hope I've explained to you the importance about why this is a priority, and things like our construct of health for Aboriginal and Torres Strait Islander people is different to the biomedical model of health. We need to be cognizant of the impact of and the complexities of social determinants of health, and we need to ensure that there's genuine Indigenous co-design, but also leadership. And so how are we doing it? We have a systematic approach to this, which will involve scoping and literature review, developing themes, and we can draw on our existing trials feasibility trials and implementations that we're leading, plus look for externals, and then follow a Delphi process, and then use dissemination. So I won't step through with you now all the steps, but we have a timeline in place to take us through that, to deliver what we hope to deliver. Now this is the copy, we can make sure you can access this or you can find it. This is the publication in JMIR Research Protocols, and it details the process we're going to undertake to develop the best practice framework. So moving forward, we have we'll continue to strengthen and grow the collaboration so that it can better reflect and help us lead this piece of work, and that'll be a key priority for the collaboration over the next 12 months, is guiding the development of the framework, continue with our feasibility trials, and also in my capacity with Flinders and as a visiting scientist with CSIRO, continue expanding our work around different health interventions and evaluations, in addition to the e-health and mHealth work. So finally, there's a few minutes left for questions. Sorry, I might have taken a bit longer than I should have, but I've also provided Georgina's contact details there too, because of her role with developing the publication. So thank you.
Thank you, Ray. That was fabulous. I'm jumping in to the end of this session, and really great talk. And I'm going to start with a few questions. So first, I wonder, how portable do you think this framework is that you've developed, the best practice framework, to other types of communities?
That's a really good question, Wendy. Look, our priority, first and foremost, is focusing on Aboriginal and Torres Strait Islander communities and people, but we'll also be mindful of that very question of how, what elements of the framework might be suitable for other cohorts and sectors. We'll keep that in our minds, but we do need to focus on our target But having said that, I would hope that there'd be many aspects of it, because it is about laying out, we hope it'll help lay out some guidance and some really important steps we would encourage people to take in co-design and developing interventions with people. And, you know, we'd hope that many of the principles would be similar, that would require, let's hope, minor adapting to suit the particular settings.
Yeah, I think if you looked at the guiding principles that you have behind it, those are really applicable all around to all of us as humans, right? Especially the leading with the respect and the idea that people are experts in their own worlds. And so as many of us embark on this e-health and digital health world, and we want to forge these partnerships, and we want what we develop to be able, we want to build partnerships with Aboriginal and Torres Strait Islander groups. But from the outside, we also realize, you know, it's not the fly in, fly out kind of thing. And there's token people that are just overburdened. How should we approach it in thinking of a long-term relationship?
Yeah, look, that's an excellent question, and it's a question, you know, we do you know, face quite often. And look, one of the key findings and one of the outcomes of my work with Andrew Goodman is through his PhD, we've been developing, I guess, an answer or a response to that very question, and we phrase it as relationships before partnerships. And it's a sort of a method with principles that you know, will in time be able to better articulate. But at its core, it's about investing time in building that sort of relationship with potential partners. And you highlighted, you know, some of the challenges that the community face, and that's the fatigue of fly-in, fly-outs and people knocking on the door with their own agenda. The approach we took with this particular work is initially working with the peak body for Aboriginal and Torres Strait Islander health here in Queensland, Quake. But that was built on a relationship I had and continue to have with people in that organisation. So it's building that sort of, bringing that sort of history of your own expertise and knowledge and respect. But I think, you know, key to it is having, you know, carving out the time to build that relationship. And we were lucky to you know, identify within the sector some services that were particularly interested in this work, but also being adaptable and flexible as well to what their needs are. And while we're experts in certain fields, if it's not what they're interested in, it's about sort of helping facilitate support for the priorities for them. Yeah, it's hard to, it is a challenge. I'm not saying it's impossible, but it is a challenge.
Yeah, but you know, that really resonates with me in terms of industry. We want to build partnerships with industry, and I know that we can't come up with projects and partnerships right away. And so we are putting years into building those relationships with the hope that together we'll come up with something that's of value to both of us. Mahima, any questions from the audience that you want to bring forward?
Yeah, there's a few. I was going to say that, Ray, please feel free to engage with the audience in the Q&A afterwards as well, but maybe in the interest of time, I'd ask one question. So one attendee is asking, as I understand from the presentation, the mHealth app was already developed prior to this project. How was it modified to address the sub-themes that were identified post the co-design process?
Yeah, no, that's a really good question. So we're in the process of finalising that adaptation, but it started with basics like making sure that we're doing the best we can to make sure that it operates within their existing IT infrastructure. Talking to clinicians, to the executive or leaders of the organisation, talking to the clinicians, including doctors and Aboriginal health workers and nurses, and also talking to patients around what it is they want to see within the platform, and about how, you know, how everything can look for them to resonate with it. But as you say, you know, you highlight a really critical point, I think, here, and this is what sped up aspects of the development of the project. Is we presented it to them to say, look, we know it works. We've trialled it in Brisbane in a hospital with non-Indigenous people. So we're not coming here to make you guinea pigs for something we think. So we know the tech kind of works. How can we improve it to fit your setting? And that it was a much more powerful discussion we were able to have with them. And we're still in the process. We're sort of 3/4 of the way through how adapting it through Andrew's PhD. But definitely the co-design foundation there.